Hello everyone. In this video, I'm going to be taking a closer look at the acute respiratory distress syndrome, which is Ards. So this is one of the most critical forms of acute respiratory failure that you will encounter in clinical practice. And understanding it early in your training, it will kind of help you recognize when the patient is heading toward a severe deterioration. That's the key thing with Ards. Um, Ards is not a single disease, it's a syndrome that develops because something else is in the body triggers massive inflammation in the lungs. That what makes it especially challenging is how quickly a stable patient can become hypoxic and how rapidly their oxygen needs escalate and how essential timely nursing recognition is. So during this lecture, I'll walk you through what Ards is, why it develops, and what is happening at the alveolar and capillary level that leads to refractory hypoxemia. So we'll also connect this to the real-world clinical practice, the signs that you'll see at bedside, the diagnostic clues, and the ventilator support strategies that become necessary as lungs become heavier, they become stiffer and less capable of exchanging oxygen. So by the end of this video, this session, you'll understand the pathophysiology, the progression, and the fundamental nursing management involved in caring for a patient with Ards. So you can recognize it early and intervene safely, confidently. All right, let's break down Ards really in a simple way and relatable way. So when we talk about acute respiratory distress syndrome, we're talking about a sudden severe form of a non-cardiogenic pulmonary edema, meaning the lungs will fill with fluid, but not because the heart has failed. Instead, something else had made the alveoli and capillaries leaky, and the fluid pours into the air spaces where oxygen is supposed to move into the blood. So if you look at the cartoon on the slide here, you can see our poor alveoli. They're stressed, they're inflamed, and they're starting to fill up with fluid. So this is exactly what Ards looks like at a microscopic level. So the lung tissue becomes damaged very quickly, and as the damage increases, gas exchange becomes harder and harder. So the blood moving past the alveoli picks up less oxygen, and it leads to hypoxemia. So now one key feature of Ards is that hypoxemia happens even when we give oxygen. So this is what we call refractory hypoxemia. So the lungs are doing everything that they can. The heart is pumping as usual, but the oxygen still can't get through because the alveoli are literally flooded. So you'll see here that Ards requires bilateral pulmonary infiltrates on the imaging. That means both lungs show this hazy fluff. They show a hazy, fluffy appearance because they're full of fluid and inflammatory debris. So at the bottom of the slide, you see the absence of heart failure. So that's important, which is important. So if this were a cardiogenic pulmonary edema, the pulmonary wedge pressure would be elevated. But in Ards, the wedge pressure is normal, so usually less than 70 millimeters per mercury. This helps clinicians kind of rule out the heart problem and confirm that the issue is coming from the lungs themselves. So now let's look at that PF ratio. So this is a quick way to measure how bad the oxygen problem is. So it's the PaO2 divided by the FiO2. So remember, the FiO2 must be in a decimal, not percentage. So the 40% oxygen becomes 0.40, and 60% becomes 0.60, and so on. So if you had the PaO2 of 90 on 40% oxygen, what you would do is that you would divide 90 by 0.0540, which falls into the mild Ards range. So that's kind of like a breakdown, and this photo actually has a little quick breakdown of how severe the oxygen is. So mild would be 200 to 300, moderate would be 100 to 200, and severe would be like 100 or less. So the lower the number, the more severe the Ards is, and more urgently the patient may need mechanical ventilation. So the big picture is that Ards is a condition where the lungs are injured of the alveoli fill with fluid. Oxygen can't move into the bloodstream effectively, and the body begins to starve for oxygen, even when we give supplemental O2. So as nurses, we need to recognize these cues very early. It's very critical because ARDS really can progress really fast. So let's talk about what makes ARDS such a serious condition and why we as nurses must recognize it early. So as we mentioned before, ARDS is a sudden and progressive form of acute respiratory failure. That means it usually comes on quickly. And once it starts, the lungs can get worse over hours to days. So the key problem is that the alveolar capillary membrane, which is the thin barrier where oxygen crosses into the bloodstream, becomes injured and extremely permeable. So when that barrier becomes leaky, the fluid rushes into the alveoli, and when the alveoli are filled with fluid, oxygen simply can't move across. So this is why patients with ARDS experience severe hypoxemia, even when we give them high levels of supplemental O2. So let's kind of look at the causes of ARDS. So there's two main pathways. We have direct lung injury and indirect systemic injury. So direct injury means that something comes into the lungs and physically harms the alveoli themselves. So this can happen from aspiration of gastric contents. That's because the stomach acid causes chemical burns in the lungs, causing injury. Pneumonia, which is infection, triggers intense inflammation. Near drowning, water damages the alveolar surface. Toxic inhalation like smoke or chemicals or any like fumes. Blunt chest trauma can cause like pulmonary contusion injury to the lungs. Even vaping injuries, which we've seen more frequently in years. So these conditions directly irritate, they inflame, or they even destroy the alveolar capillary membrane, causing fluid leakage and poor oxygenation. Indirect injury is when the lungs are not the primary site of the problem, but they become affected because of massive systemic inflammation. So those common causes include like gram-negative sepsis, which is the #1 cause of ARDS, pancreatitis, which the enzymes and the inflammatory mediators spill into the bloodstream, massive bloodstream transfusions, which is the transfusion-related acute lung injury, and even like fat or amniotic fluid embolisms can cause this. So in these cases, the body's inflammatory response becomes so widespread that it damages the lungs even through the initial problem, which was in the chest. So whether the injury is direct or indirect, the end result is pretty much the same. It increases the inflammation, increases permeability, fluid-filled alveoli, and it causes severe hypoxemia. So we need to recognize these causes kind of in order to help us understand why the patient is heading toward respiratory distress, and it supports quicker identification and early intervention and safer care. Everything we talked through on the last slide is shown here in a visual way. Sometimes seeing the process helps make the causes of ARDS easier to understand. Okay, so let's talk about the first phase of ARDS, which is called the injury phase or the exudative phase. So this is where everything begins. So this phase usually starts 24 to 72 hours after the initial insult, whether that insult was direct, like pneumonia or aspiration, or indirect, like sepsis or pancreatitis. This early phase typically lasts about 7 days. So what's kind of actually happening inside the lungs during this time? So the first big change is inflammation. The tissue around the bronchi and blood vessels, the peribronchial and the perivascular areas become swollen. So this swelling in the interstitial space is called interstitial edema. So as the inflammation worsens, that fluid begins to cross the alveoli membrane and actually enter the alveoli. And remember, the alveoli are supposed to be air-filled, not fluid-filled. So once the fluid enters the alveoli, gas exchange becomes extremely difficult. This leads to VQ mismatch and intrapulmonary shunting. And why do you think that is? It's because parts of the lungs are getting ventilation, but the fluid-filled alveoli can't participate in the oxygen exchange. So the blood flows past them without getting oxygenated. Another major issue is the damage to the type 1 and type 2 alveolar cells. So the type 1 cells are responsible for gas exchange, and type 2 cells, they produce surfactant, so which kind of keeps the alveoli open. So when these cells are damaged, we lose both the effective gas exchange and surfactant function. Without surfactant, the alveoli become sticky and they start to collapse, which gives us widespread atelectasis. As more of the alveoli fail, the blood passing through the capillaries become poorly oxygenated, contributing to severe hypoxemia we see in Ards. So we also see necrotic cell debris and protein leaking into the alveoli. This material forms what's called the hyaline membrane. So think of it like a stiff protein-rich coating lining inside the alveoli. This membrane further blocks oxygen movement and can eventually contribute to lung fibrosis. So the big takeaway from this entire phase is that the patient develops severely impaired gas exchange, severe VQ mismatch, shunting, and decreased lung compliance. So that means the lungs become stiffer, heavier, harder to ventilate, and much less responsive to oxygen therapy. So this is why patients in the exudative phase of ARDS often require escalating oxygen support, and they may need mechanical ventilation to maintain adequate oxygenation. Now we're moving on to the second phase of ARDS called the reparative phase or the proliferative phase. So this phase usually begins 1 to 2 weeks after the initial lung injury, whether that injury was direct like pneumonia or indirect like sepsis. So even though this phase is called reparative, it doesn't mean the lungs are healing yet. So in fact, the lungs are still very inflamed and the body is actually trying to repair the damage, but sometimes the repair process causes more problems. So during this stage, the inflammatory cells begin damaging not just the alveoli, but also the pulmonary vasculature. So the blood vessels, that means like the blood vessels. So when that happens, the patient may develop increased pulmonary vascular resistance, which can lead to pulmonary hypertension. So this makes it harder for the blood to flow through the lungs, which adds another layer to the oxygenation problem. So because of the ongoing inflammation, the lungs begin forming fibrous tissue. Think of it like a scar tissue. So as more fibrosis develops, the lungs become stiffer, which means the lungs compliance continue to decrease. Stiff lungs are kind of difficult to ventilate, and this stiffness contributes to the worsening hypoxemia. So the thickened fibrotic membrane surrounding the alveoli further interferes with the oxygen movement. So hypoxemia can worsen during this phase, and we continue to see the VQ mismatch and shunting. So blood still moves through the lungs, but it doesn't pick up the oxygen effectively. So patients may also experience an increase in airway resistance because they often have more secretions and fluid inside the airways. So this means the ventilator has to work harder to push air in, and the patient may require higher pressures. So this phase is considered complete when the damaged lung tissue becomes replaced with dense fibrous tissue. So that's not always a good thing. Too much fibrous limits the patient's ability to recover normal lung function. So the hopeful part is that the patient begins to stabilize. The fibrotic lesions can start to resolve, and the lungs may slowly begin healing. But if the inflammatory process continues and the body doesn't shift into recovery mode, the fibrosis can become widespread, and that can have a long-term effects on lung function. So the big takeaway here is that during the proliferative phase, the lungs are still inflamed, they are still stiff, they're still struggling with oxygenation, and they're starting to form scar tissue. So the goal during this time is supportive care, preventing any further injury, and giving the lungs a chance to start turning the corner toward recovery. Now we're moving into the third phase of ARDS, called the fibrotic phase, or the fibroproliferative phase. So this phase usually begins 2 to 3 weeks after the initial lung injury. So this is the later stage of ARDS. The important thing to understand right away is that not all ARDS patients reach this phase. Some begin to recover during the earlier phases, and their lungs start healing before fibrosis becomes severe. But for patients who don't recover early, the lungs begin undergoing major structural changes. So in this phase, the body has been trying to repair the injured lung tissue for so long that it begins laying down fibrous tissue, which is basically scar tissue. So over time, the lung tissues become completely remodeled. They become stiffer, thicker, and much less flexible. This leads to diffuse scarring, interstitial fibrosis, and alveolar fibrosis. So all of this scar tissue makes the lungs very difficult to expand, which means the patient's lung compliance is significantly decreased. In other words, the lungs become so stiff that it takes much more pressure to ventilate them, and even then, the gas exchange remains poor. So for some patients, this fibrosis becomes permanent. So if the lungs don't begin to healing or reversing that scar tissue, the patient can be left with long-term respiratory limitations, or they may require prolonged mechanical ventilation. So the key takeaway for this phase is if healing does not occur early on, the lungs may progress into a fibrotic, scarred state that is very difficult to treat and has long-term consequences for breathing and oxygenation. So that's why we need to really early recognize what ARDS is in the earlier phases, so we can treat ARDS early, which is so important for us to do. We want to prevent patients from ever reaching this stage. Again, here's a visual of what the phases, the various phases I discussed in the previous slides, just to kind of give you a visual of what's going on with the lungs. And this slide is just more of a simpler breakdown of each phase, just to kind of break down and have the key highlights of each phase. So that's what this slide represents. Okay, so let's walk through the clinical signs and symptoms that you'll see in a patient developing ARDS. So these are the bedside clues that tell you the lungs are struggling long before lab results or chest x-ray confirm it, right? So you'll see the patient will have dyspnea, which is mild at the beginning. So at first, the patient just may feel a little shortness of breath. This happens because the alveoli are starting to fill with fluid. So the oxygen doesn't move across the lung tissue as easily. So the patient may tell you, I just can't catch my breath. So they may say something like that. They'll have tachypnea, which is to compensate for poor oxygenation. So the body increases the respiratory rate. So the brain senses low oxygen and sends the message, breathe faster. So this often is one of the earliest and most important signs for you to recognize. They might have a cough, which is usually dry at first. It develops because the lungs are irritated, they're becoming inflamed and filling with fluid. So the body tries to clear the airways, even though coughing doesn't help improve the gas exchange in ARDS. They will have a restlessness, which is another one of the best early indicators of hypoxemia because the brain is extremely sensitive to low oxygen levels. So the patient may look anxious, fidgety, or even just not right, So always take restlessness seriously in respiratory patients. That should be on your high alert. Increased work of breathing. As more alveoli collapse or are filled with fluid, the patient has to use more effort to breathe. So you'll see them take some deeper breaths. They'll have visible muscle use, nasal flaring, accessory muscle engagement. So the patient is literally working harder to pull air into the stiff, non-compliant lungs. They'll have intercostal retractions because the lungs are stiff. They're not expanding well. The muscles between the ribs pull inward with each breath. So this is a sign of severe respiratory distress. So the patient is doing everything it can to expand the lungs against the increasing resistance. Again, they'll be tachycardic. So that because the heart beats faster to try to compensate again for the low oxygen. So if the blood isn't carrying enough oxygen, the heart pumps more quickly in an attempt to circulate what little oxygen is available. They'll experience diaphoresis, diaphoretic. Patient becomes sweaty and clammy. So this is a sympathetic nervous system response to stress. So when the body senses danger, like falling oxygen levels, it releases stress hormones, causing sweating. Um, Change in mentation that I just mentioned earlier. So as hypoxemia worsens, the brain becomes oxygen deprived. So you may notice confusion, irritability, decreased responsiveness, trouble following commands. So this is a late and dangerous sign. So the brain is not getting enough oxygen. So cyanosis, again, later stage. They may have like blue lips, blue nail beds, is a very late sign of hypoxemia. So this means the patient's tissues are extremely deprived of oxygen. So if you see cyanosis in ARDS, the situation is now life-threatening and it requires immediate intervention. So early ARDS shows up as increased work of breathing, restlessness, and tachypnea. Later ARDS shows severe hypoxemia, mental status changes, and cyanosis. So these clinical signs help you recognize ARDS before labs and imaging catch up. So your bedside assessment is what saves lives. So looking at how ARDS is diagnosed, so as nurses, we play a huge role in recognizing these early clues because ARDS can progress quickly, like I mentioned earlier, and it's silent. How you really recognize that is through lungs auscultation. So when you listen to the lungs, the sounds change as the condition worsens. So that's why it's so important. I can't stress it enough to get a really good, thorough baseline um, assessment, including listening to lungs, especially people who have respiratory issues or sepsis or anything like that. But it's always good to get a good, solid physical assessment so you can recognize any changes. So in the early stages, you may hear fine scattered crackles. So these are small popping sounds that caused by tiny airways opening and closing as the fluid begins to accumulate. So as ARDS progress, these crackles become more pronounced and widespread. So eventually turning into diffuse coarse crackles throughout. And this happens because there's more alveoli are filling with fluid and they're collapsing, so leading to worse gas exchange. Again, next we'll see ABGs. They tell us what's happening inside the lungs at the gas exchange level. So in early stages, the patient may show mild hypoxemia, and because they're breathing fast, hyperventilating, they blow off too much CO2. So this causes respiratory alkalosis. So you see a low CO2 and a high pH. As ARDS worsen, the patient becomes fatigued and maintain that rapid breathing. So hypoventilation sets in and CO2 begins to rise. So this leads to respiratory acidosis. So high CO2 and low pH align with a severe hypoxemia that doesn't improve even when you give oxygen. So that is called like refractory hypoxemia, which is one of the hallmark signs of ARDS when they're not responding to any oxygen. On a chest x-ray gives you a visual picture of how much lung tissue is affected. So in early findings, the x-ray might look normal or show minimal scattered infiltrates, which can easily be missed. In the progression ARDS, as it progresses, these infiltrates spread and become bilateral and more interstitial and alveolar, which meaning that both lungs are being filled with fluid and inflammatory debris. At the severe and end stage on an x-ray, it becomes a classic whiteout. So you no longer see as distinct lung markings or air-filled spaces. So it looks almost entirely opaque because the alveoli are filled with fluid, not air. So that is one of the most recognizable radiographic signs of advanced ARDS. So Ards diagnosis kind of relies on what you hear, so crackles or coarse crackles, um, what you see in the labs, hypoxemia that worsens, ABG changes from alkalosis to acidosis, and really what images shows, which is normal, to bilateral infiltrates to whiteout, which is severe. So these findings can help confirm ARDS and guide to really to urgency of treatment. Here are additional diagnostic workups for ARDS. So remember, ARDS is a diagnosis of exclusion, meaning that we first have to rule out other causes of respiratory failure before we can confidently say it's ARDS. So the diagnostic tools help us build, help us build a whole picture. I already talked about like the chest x-ray. That can help us rule out any other causes of respiratory distress, such as like atelectasis, which is a collapsed lung units, pneumonia and COPD exacerbation. So if the imaging doesn't match those conditions and instead shows diffuse bilateral infiltrates, or start thinking about ARDS, right? And then we're looking at the blood gases. Again, I discussed that in an early slide. But again, we use them to evaluate the severity of hypoxemia, whether the patient is in respiratory alkalosis, which is early stage, or acidosis, which is late stage. So how well the lungs are exchanging oxygen and CO2. So they also help us calculate the PF ratio, which is needed to formally diagnose ARDS. Vital signs, pulse oximetry. So these gives us immediate real-time clues about the patient's condition. Trends in respiratory rate, increased work of breathing, dropping the SpO2 despite oxygen therapy, changes in the heart rate and blood pressure. So these are early warning signs before labs come back. CBC, which is a complete blood count, helps us identify any infection. So you'll see elevated white blood cells. That also could indicate possible sepsis, which sepsis is a #1 cause of ARDS. One of the common causes, anemia, which worsens oxygenation, other conditions contributing to the patient's respiratory status. So again, like I said, sepsis is the #1 cause of ARDS, so the CBC is essential to obtain. Basic metabolic panel, so these assess the electrolytes, any renal functions, or acid-base imbalance or balances. Metabolic changes often accompany ARDS, so especially in septic or critically ill patients. The 12-lead EKG helps us rule out any cardiac ischemia, dysrhythmias, or any heart failure. So we need to make sure hypoxemia isn't coming from a cardiac cause in order to suspect ARDS. So blood and sputum cultures, because infection, especially sepsis or pneumonia, it's a common cause of ARDS. So cultures help us identify the pathogen, and we can start targeting antibiotics. Or targeted antibiotics, according to the blood cultures results. CAT scan can give us more detailed picture of the lungs, so it can show early infiltrates, pulmonary edema, areas of a consolidation, exclusion of pulmonary embolism. So they kind of give you a detail and a more accurate diagnosis. The VQ scan. So it's a ventilation perfusion scan that can help rule out pulmonary embolism, which may be present with acute respiratory symptoms that are similar to ARDS. The end-tidal CO2 gives us a quick look at how well the patient is ventilating, the CO2 clearance, potential fatigue, how they're doing, early signs of respiratory acidosis. So it is especially important when caring for intubated patients or rapidly deteriorating patients to end-tidal CO2, which is very important to monitor in those conditions, in those situations. Hemodynamic monitoring, like a CVP or arterial line. So if they're really critically ill, ARDS patients really often require that CVP monitoring, which also helps us assess fluid status. On the arterial line, it gives us continuous blood pressure readings, and that's where we can get the frequent ABGs from. This data kind of helps us guide ventilator settings. It helps with fluids, vasopressors management, and overall management of this. So diagnosing ARDS, it kind of requires a combination of clinical signs, ABGs, imaging, and lab results to rule out other causes and confirm the presence of non-cardiogenic pulmonary edema with severe hypoxemia. Okay, so I'm just going to take a little quick look at the end-tidal CO2 that I mentioned earlier, which is incredibly useful tool when caring for mechanically ventilated patients. So capnography, it allows us to monitor a patient's ventilation in real time. So it reflects in like three major things, right? How much CO2 the body is producing, how well the lungs are perfused, and how effectively the patient is ventilating, basically. So the waveform you see on the monitor is called a capnogram. So, and it shows the CO2 level at different points in breathing cycles. So one of the most important uses of waveform capnography is confirming proper endotracheal tube replacement. So if you see a nice consistent waveform, the tube is in the trachea. So if the waveform disappears suddenly, you should immediately think about a problem like dislodgement or disconnection. So the number we pay attention to is the CO2 at the end of exhalation, so which is the end-tidal CO2 value. Normal end-tidal CO2 is around 35 to 45, which closely correlates with the patient with the PA CO2 on the ABG. Capnography also helps us assess ventilation status. So a high end-tidal CO2 suggests hypoventilation or CO2 retention. A low end-tidal CO2 suggests hyperventilation or poor perfusion. And during CPR, just kind of a little tidbit, end-tidal CO2 is essential. So when we're doing high quality chest compressions, typically generate an end-tidal CO2 of 10 to 20 millimeters per mercury. So if that number suddenly rises, it may indicate return of spontaneous circulation. If so, in short, the end-tidal CO2 is a fast, reliable way to assess ventilation, perfusion, tube placement, and to see if the CPR is effective, and all in one simple waveform, basically. So here are some of the complications associated with ARDS, specifically those related to mechanical ventilation, because many ARDS patients end up intubated for long periods of time. So ventilator-associated pneumonia, which is VAP, is one of the biggest risks for ARDS patients is that. So when a patient is intubated, the endotracheal tube keeps the airway open, but it also creates a pathway for bacteria to enter the lungs. So even with perfect care, the tube prevents the patient from clearing secretions normally, which allows bacteria to accumulate. So add that fact that ARDS patients often require prolonged mechanical ventilation, sometimes for days, even weeks, and the risk increases even more for that. So there's always a risk of aspiration, secretion, saliva, or gastric contents getting past the tube cuff and into the lungs. So aspiration can directly cause pneumonia or make that much harder to treat. So overall, VAP is a serious complication that can worsen the patient's oxygenation and then prolong their ICU stay. That's why we have that ventilator bundle that we call that when somebody's intubated. So this is to reduce the risks of VAP. So we follow that ventilator bundle. It is a set of evidence-based interventions proven to prevent pneumonia in ventilated patients. So these are all nursing-driven interventions, which means that you can play a key role in preventing ventilator-associated pneumonia. So in that bundle includes like hand hygiene. So this is a #1 defense. Every time that you touch the vent circuit, suction the patient, or even perform oral care, hand hygiene is essential to prevent any introducing bacteria. Elevating the head of the bed 30 to 45 degrees helps prevent aspiration by keeping the stomach contents from moving upward. So this single intervention greatly reduces pneumonia risks. Daily assessment of readiness to extubate. So every day the team evaluates whether the patient can safely come off the ventilator. So the shorter the time on the ventilator, the lower the VAP risk. You know, Oral care every 2 hours with chlorhexidine. So that helps removes the bacterial buildup in the mouth, which reduces the number of organisms that can trickle down the airway. So chlorhexidine adds that extra antimicrobial effect. Suction the patient, removing secretions regularly, prevents them from pooling above the cuff, and it reduces the risk of aspiration. So it does help maintain the patent. So it helps maintain patent airway. That's our goal with these things. So preventing complications like VAP is nursing driven. So your care, oral hygiene, suctioning, head of the bed elevation, and vigilance can really directly impact whether the patient gets better or develops another serious infection. So you are really essential to preventing secondary complications of Ards. So continuing on with more complications of Ards, which so much can occur when a patient develops Ards. So barotrauma is one of them. It happens when the alveoli are exposed to too much pressure during mechanical ventilation. So in Ards, the lungs are stiff and not compliant. So the ventilator often has to use higher airway pressures to get air into the lungs. And by doing this, we use the PEEPs, and we'll talk more about that in mechanical ventilators. So the problem is that Ards makes the alveoli fragile, inflamed, and easily damaged. So what happens that these fragile alveoli, they become over-distended from the pressure. So if the pressure gets too high, the alveoli can rupture. So when the alveolus ruptures, air can't escape into the places it shouldn't be, where it shouldn't be. So that can lead to a normal pneumothorax, where that means that air leaks into the pleural space and collapses the lungs, or interstitial emphysema, where that air gets trapped in the tissue spaces. So this is why ventilator settings matter so much, especially in Ards. So the lungs need gentle ventilation, low tidal volumes, and careful pressure monitoring to avoid any injuries. Stress ulcers is another complication in Ards patients, which occur in the stomach and the GI tract. And this is because when the body is under severe stress, like in Ards, it redirects blood flow away from the GI tract and toward the vital organs, which especially the lungs and brain. So less blood flow in the stomach means that protective lining becomes weaker, making it more vulnerable to acid and ulcer formation. So nursing considerations, as nurses, we need to monitor for any like GI bleeding, such as if we notice any like coffee ground emesis or black stools, we need to report that. We need to treat the underlying issues like hypotension, shock, or acidosis. Anything decreasing GI perfusion, we need to pay attention to. Medications that help this would be like the PPIs, like Protonix, that kind of reduces that stomach acid. Any mucosal protectants like Carafate, because that coats the stomach and protects against injury. Or some early enteral feedings, which are tube feedings, can help maintain the gut integrity and reduce ulcer risks. So that way because the gut needs nutrition and blood flow to stay healthy. So we may introduce that. So barotrauma happens because the ventilator has to work harder to push air into stiff lungs, which can cause alveolar rupture. So we need to look out for that, like signs and symptoms of pneumothorax or interstitial emphysema. Stress ulcers can happen because the stress body sacrifices gut blood flow to support the lungs. So we need to really understand these complications so we can anticipate any of these problems early on, and that way we can intervene before they even escalate. Moving on to more complications that we can, like I said, so many complications that can occur for a patient who develops Ards. So venous thromboembolism. So Ards patients are at very high risk for VTE, which includes deep vein thrombosis, DVT, and a pulmonary embolism. So why does that happen? Usually most Ards patients are immobile, sedated or paralyzed, lying in bed for long periods, so experiencing any venous stasis like blood pooling in the legs. So when blood isn't moving, it clots. And when a clot forms in the leg and it breaks off, it can travel to the lungs and can cause a pulmonary embolism, which can be life-threatening, and especially in already hypoxic ARDS patients. So what we do as nurses, our preventative measures as nurses, we may be giving them like subcutaneous, like heparin or Lovenox, which can prevent any clot formation, sequential compression devices like the SCD boots to keep that blood moving, and early ambulation when possible, because that promotes circulation and reduces clot risks. So that's why, as nurses, preventing VTE is one of our key responsibilities in the ICU setting or any setting in a hospital setting. Acute kidney injury is another complication of ARDS, which is often due to poor kidney perfusion. And this happens because the kidneys need a steady supply of oxygen-rich blood to function. So in ARDS, oxygenation is already compromised, so the kidneys may not be getting the oxygen that they need. Hypotension is a common in ARDS as well, and sepsis, so that also reduces blood flow to the kidneys. So this leads to ischemia, which can damage kidney tissue. So what we need to do to monitor is make sure, because some of these patients can get nephrotoxic drugs like certain antibiotics or contrast dye, so they can actually worsen the kidney injury as well. So we need to monitor, because we may be giving those meds. They also may be on a strict INO, so that tells us if the kidneys are producing enough urine, so we're going to monitor that as well. And we're also going to monitor labs like the BUN and creatinine levels to track any kidney function. So if a kidney injury progresses, the patient may require dialysis to support their kidneys until recovery. So ARDS doesn't just affect the lungs, it affects the whole body. So immobility can result into blood clots. Poor perfusion and low oxygen can result into acute kidney injury. So as nurses, preventative care is pretty much mobility, medication administration, SCD boots, hydration, INO monitoring, and which can really make a difference between recovery and serious organ failure. So as I said, ARDS can cause multiple problems and complications in patients that actually develop ARDS. So also it can decrease cardiac output. So this happens when oxygenation is poor and the lungs are stiff. The heart has to work harder. So add in low blood pressure, fluid shifts, and high ventilator pressures, and the heart may not pump effectively. So this leads to decreased cardiac output, which worsens perfusion to vital organs. Dysrhythmias, because of low oxygen levels, electrolyte imbalances, acid-base changes in medication, they can trigger arrhythmias. So these can range from harmless PVCs to life-threatening rhythms. Hemodynamic instability, this is where vasopressors will be needed. So in ARDS, patients often become hypotensive due to sepsis, the sedation that we use medications for that, mechanical ventilation, pressures, or poor cardiac output. So when the fluids aren't enough, we need vasopressors like norepinephrine to support blood pressure and keep the organs perfused. Delirium. So ICU delirium is extremely common, and it happens from hypoxemia, sedation, paralytics, sleep deprivation, inflammation. So patients may become confused, agitated, or even hallucinate. So that's a serious safety concern that we got to consider. PTSD. So many ARDS survivors experience long-term psychological effects after being sedated, intubated, or critically ill. PTSD can develop from frightening ICU experiences, loss of control, or traumatic memories. Paralytic ileus. So the intestines slow down or stop moving. And why do you think that? I mentioned it earlier. So because they reduce blood flow to the GI tract, or medications like sedatives or opioids can slow down the GI tract. Even stress response. which can lead to distension, nausea, vomiting, and intolerance of enteral feeds. Stress ulcers or GI bleeding. Critically ill patients divert blood away from the stomach to vital organs. So this makes the stomach lining fragile and prone to ulcers. So without PPI prophylaxis, these ulcers can bleed. So disseminated intravascular coagulation, DIC. So this occurs because severe inflammation and sepsis can trigger abnormal clotting throughout the body. So patients they form microclots everywhere, which then runs out of clotting factors, which then bleeds out. So DIC is life-threatening complication, often linked to severe ARDS or sepsis. DVT or PE, and this is because ARDS patients are often immobile and sedated. They are at risk for high blood clots, so these can travel to the lungs and cause pulmonary embolism, making respiratory failure even worse. Acute kidney injury because of the poor oxygenation and poor perfusion, therefore kidneys suffer. So you'll see like hypotension. This is because hypotension or sepsis or any like nephrotic drugs and low cardiac output all contribute to this. So some ARDS patients may require dialysis. Catheter-related infections, cardioclampsia. So with central lines, Foley catheters, and multiple access points, infection risks go up. So these infections can worsen sepsis and prolong ICU stay. So strict aseptic technique is really critical when we're accessing these IV sites. Sepsis is both a cause and a complication of ARDS. So as critical illness progresses, patient can develop new infections, pneumonia, bloodstream infections, urinary infections, which then worsen inflammation and organ failure. So ARDS really affects every organ, right? So your nursing care, monitoring trends, preventing complications, and early detection, it really does play a huge role in survival and long-term outcomes. So let's go through an assessment. So when a patient is this unstable, your assessment becomes absolutely critical. So we always want to start with a thorough history if we can, like what happened, what symptoms were present earlier, what does the underlying conditions the patient has. That information helps us identify the cause of ARDS. But in reality, many ARDS patients are so sick when they arrive that there isn't time for long history. So the priority becomes protecting the airway. So that means preparing for intubation, setting up for mechanical ventilation, or establishing any like hemodynamic monitoring lines like a CVP or ART line. So once the airway and circulation are stabilized, then we move on into a focused head-to-toe assessment. So let's start with a neuro assessment. So we're kind of like, what we're asking is, how is the brain perfusing? So because low oxygen levels can cause restlessness, confusion, decreased level of consciousness, agitation, or delirium. So these are early signs of worsening hypoxemia. So the cardiac assessment, because the heart compensates for hypoxia, you may see tachycardia, dysrhythmias, low blood pressure, decreased cardiac output. So remember, ARDS patients often require vasopressors to maintain any organ perfusion. Our pulmonary assessment, this is the most important area that we need to assess. So we're looking at their work of breathing, auscultating their lung sounds. Are there crackles? Or diminished breath sounds, their end-tidal CO2 or ABG results. We need to look at that. And how are they tolerating to the ventilator settings? And also their SpO2 trends. So we want to quickly recognize if the patient is tiring out or if the gas exchange is worsening. So we make GI assessment. And in critical illnesses, that also affects the gut too. So we need to watch out for paralytic abdominal distension, any GI bleeding, What do they look like? What are the signs and symptoms for that? Any tolerance of, and if they're tolerating any tube feedings. So early enteral feeding helps protect the gut, like I mentioned earlier, but you must also assess if the patient is really tolerating it as well. So in ARDS, your patient assessment must be rapid, systematic and focused. So stabilize the airways, support the circulation, and then perform a multi-system assessment like neuro, cardiac, pulmonary, and GI. And this is to identify any early complications that will guide our interventions. So now we're talking about what we actually do as nurses when caring for a patient with ARDS. So this is where your critical thinking, your vigilance, and assessment skills really matter. So ARDS patients are some of the sickest in the hospital, and nursing care directly affects their survival. So first thing we need to do is we really want to make sure that their PA2 is within normal limits. So one of our biggest goals is maintaining a safe PO2 level on an ABG. So even the small drops in the PaO2 can have serious consequences in ARDS. So we're constantly adjusting oxygen therapy and ventilator settings to maintain any adequate oxygenation. We want to maintain it as SA2 greater than 90% SpO2. So this ensures that the tissues are getting enough oxygen they need. Anything below this is a red flag that the patient may be decompensating. Ventilation isn't just about oxygen, it's also about CO2 removal in order to provide adequate ventilation and maintain a normal pH. So poor ventilation can cause respiratory acidosis. So too much ventilation can cause respiratory alkalosis. So our goal is to maintain a stable pH by making sure that the patient is ventilating effectively. So frequent ABG monitoring. So they help us guide almost every decision like oxygenation, ventilation, any acid-base status and response to interventions. So in ARDS, the ABGs are checked frequently because the patient's condition can change rapidly. So in IV fluid management, this is a delicate balance. So ARDS patients often need fluids for perfusion, but too much fluid kind of will worsen pulmonary edema. So nurses monitor fluids closely to maintain any hemodynamic stability without flooding the lungs. The analgesia, sedation, and paralytics. So many ARDS patients are on ventilators, so they require deep sedation, and many need paralytics to improve oxygenation. So we're going to need to monitor sedation levels, maintain safety, and prevent complications like delirium and skin breakdown. Also, as nursing, we need to identify and treat any of the underlying cause. So ARDS is always the result of something else, like pneumonia, sepsis, aspiration, even trauma. So we need to treat the source, which is key to improve the lungs. CVP and arterial line monitoring. So these lines help evaluate the blood pressure, our fluid status, tissue perfusion, response to like vasopressors or fluids. So accurate monitoring is really essential for guiding our interventions as well. Nutrition therapy like enteral feeding. So the gut needs early feeding to prevent breakdown and ulcer formation. So enteral nutrition supports immune function and healing, and it reduces risks of sepsis. Then we have the VTE prophylaxis that I mentioned earlier. So because of ARDS, patients don't move much. They're at high risk for blood clots. So we use like heparin or Lovenox, the SCD boots, early mobility if possible. So this is what we need to kind of like think about when this is all like in our nursing care. And this is because clots can be fatal. So prevention is really critical in that. VAP prophylaxis, like ventilator-associated pneumonia, that can worsen ARDS. So we need to prevent it with like oral care with the chlorhexidine swab every 2 hours, head of the bed elevation, suctioning, hand hygiene, and daily readiness to like extubate assessments. So Vasopressor drugs. So if the patient is hypotensive or in septic shock, vasopressors may be required to maintain a mean arterial pressure map. So that keeps organs perfused. So nurses monitor them closely for effectiveness and side effects. So our kind of like key takeaway for all this, for what we need to do as nurses, um, that taking care with somebody with a patient with ARDS is really complex. But we have to really be vigilant in monitoring and supporting and preventing complications and stabilizing the patient. That's our primary goal. So we have constant eyes and ears at the bedside, so we're looking at them 20 as those 12-hour shifts while we're there. So we really need to be vigilant about our assessments and the monitoring and all that good stuff. So our interventions really do make a difference on patient outcome. So this image highlights monitoring tools commonly used in critical ill or sedated patients, especially those with ARDS who may require sedation, paralysis, or close neuro and respiratory monitoring. So the electrodes placed on the patient's wrist and connected to a small device show a TOF monitoring. So TOF is used when a patient is receiving neuromuscular blocking agents like paralytics. It assesses the degree of paralysis by delivering small electrical impulses to the nerve. So the nurses use it to make sure that the patient is over paralyzed or under paralyzed, right? So it helps titrate paralytics safely. So the TOF stands for train of 4 monitoring. Then you have the bottom left image, which is the bispectral index monitoring. So the electrodes placed on the patient's forehead represent the BIS monitoring, which measures the sedation depth. So it's used in sedated or paralyzed patients who cannot communicate pain or wakefulness. So the BIS values guide sedation. So any between a score of like a number between 40 to 60, that indicates that they're in deep sedation, like anesthesia. And 60 to 80 is moderate sedation. So it prevents both under sedation, wakefulness while paralyzed, or over sedation. The bottom right image is an advanced respiratory sedation monitor. This device displays respiratory waveforms, oxygen saturation, and possibly ventilation parameters. So that shows the end-tidal CO2, the SpO2, respiratory rate, and other advanced respiratory data. It helps us nurses continuously monitor ventilation quality, oxygenation, and sedation response. It's essential for ARDS patients who are already mechanically ventilated. So these tools kind of ensure patients remain adequately sedated, ventilated, and safely managed while they're critically ill. Okay, so now we're going to talk about oxygen administration in patients with ARDS. And how we manage oxygen in patients with ARDS. So remember, ARDS is not just about low oxygen, it's about alveoli that are filled with fluid and also that are collapsed or too stiff to work. So our oxygen strategy, needs to match what's actually happening in the lungs. So our first priority is simple. We need to correct the hypoxemia. So ARDS patients often arrive with dangerously low O2 levels, so we immediately start giving supplemental oxygen to stabilize them. With the high flow oxygen as the first step, so we usually begin with a high flow oxygen system because it can deliver a high concentration of oxygen quickly. Because high flow oxygen, it washes out CO2 and it reduces work of breathing, provides heated, humidified oxygen, and it gives up to like 60 liters per minute flow. So this often buys us time in those like first critical moments there. But high flow is only temporary because it really does not fix the collapsed alveoli. The problem in ARDS isn't just low oxygen, it's the alveoli that are collapsed, either filled with fluid or they're inflexible. So all the O2 in the world will not help if the alveoli can't open or participate in gas exchange. Remember that VQ mismatch we're talking about? So that's why high flow is just a short-term measure at this point. The next step after that would be mechanical ventilation. So if the patient doesn't respond to high flow, and many ARDS patients won't, the next step is intubation and mechanical ventilation. That lets us control the patient's breathing. It gives precise amounts of oxygen, and it adjusts the ventilation to maintain the pH. And most importantly, it allows us to apply PEEP. So that's positive end expiratory pressure. So why does that matter more than oxygen? So in ARDS, the real issue is the alveoli that are collapsed or flooded. So the PEEP, the positive end expiratory pressure, it opens those alveoli and it keeps them from collapsing again. So think of the PEEP as splinting, the alveoli open. So it is essential because oxygen alone cannot open collapsed alveoli. So the PEEP improves oxygenation by increasing the number of working alveoli, right? So it also helps reduce shunting and also allows gas exchange to actually occur. So mechanical ventilation isn't just about giving oxygen, it's about recruiting alveoli so that oxygen can be used. So high flow oxygen is just a bridge, so remember that, because it's not a solution. Most ARDS patients need mechanical ventilation because we must fix alveolar collapse, not just oxygen level. So PEEP is one of the most important tools in managing ARDS because it keeps the alveoli open and functioning. So remember that. So proning position is pretty much probably one of the most important nursing interventions for an ARDS patient who's not responding to oxygen therapy. So in early stages of ARDS, fluid moves fairly freely throughout the lungs, but as the condition progresses, gravity takes over and the fluid starts to settle into the dependent, which is the lowest parts of the lungs. So when the patient is lying on their back, which is supine, those dependent regions are the posterior lungs, which end up becoming heavy, fluid-filled, and collapsed. So this is a problem because when a patient is supine, the heart and mediastinal structures press down on the lungs, further compressing the alveoli. So this extra weight makes it harder for the already fragile ARDS lungs to expand. So in fact, the supine position predisposes these patients to atelectasis, poor oxygenation, and worsening hypoxemia. So proning turns the patient onto their stomach, shifting the weight of the heart and abdomen away from the posterior lungs. So this has several benefits. It redistributes fluid, relieving pressure on the collapsed alveoli. It allows previously compressed alveoli to re-expand and participate in gas exchange. It also improves ventilation and perfusion, which is our VQ matching, which is critical in refractory hypoxemia. It also improves oxygenation when nothing else seems to help. So this is why prone positioning becomes so widely used during COVID-19 ARDS cases. So we need to watch out for any fluid shifts inside the chest and abdomen when the patient is turned prone. Some patients can become hemodynamically unstable at first. So you might see a drop in blood pressure, dysrhythmias, changes in oxygenation. So close monitoring is essential during and after the turn. Patients with severe ARDS, they're commonly remain prone for up to 16 hours a day. So when they're finished with prone therapy, we don't put them flat on their back right away. Instead, we place them on their lying position to prevent any fluid from immediately shifting back into the posterior lungs. So Prone positioning is one of the most effective interventions, like I said before, for improving any oxygenation in Ards because it opens up the collapsed alveoli, improves the VQ mismatching, the VQ matching, and it reduces the pressure of the heart and diaphragm on the lungs. So it is a powerful tool, but it also requires a skilled nursing care, coordination, and close monitoring. So this photo shows prone positioning support cushions, which are used to safely position patients on their stomachs. So the cushions help support the face without putting pressure on the eyes. It protects the airway tube and prevent accidental extubation. Produces pressure. It reduces the pressure on the chest, breast, and pelvis. It maintains proper spinal alignment, and it prevents any skin breakdown and nerve injury. So these devices make a long-term proning, often 16 hours a day, safer and more comfortable for the patient. And as you can see, this is what a patient would look like when they are in prone positioning. A lot of them, like I said, they're on a ventilator support machine, or intubated.